Hello and welcome, dear students. Today we are going to discuss an important topic of endocrinology, that is parathyroid gland, its structure, functions, regulation and disorder. The main objective of today's lecture are to get a brief idea about parathyroid gland in general, to know about the structure of the parathyroid gland, to describe its functions, to briefly understand the regulation of its activity, and then finally we will discuss the disorders in general. To begin with, let us first discuss the structure of parathyroid gland. The parathyroid glands arise from the endoderm of the embryo and are situated on the posterior surface of the thyroid lobes as shown in figure. The parathyroids are 4 small flat oval bodies, each with the size of a pea, 2 on each side. Microscopically, the parathyroid glands contain 2 distinct kinds of densely packed epithelial cells, namely the chief cells and the oxiphyll cells, surrounded by a thin layer of connective tissue. The chief cells are more numerous and small with a clear cytoplasm containing small dense granules. These cells secrete parathyroid hormone, also called Colip's hormone, named after its discoverer, which regulate calcium and phosphate metabolism. The oxiphyll cells are larger with a less granular cytoplasm, but its function is not known in a normal parathyroid gland. However, histologically, due to its unique staining characteristics, its presence clearly helps to identify the parathyroid gland. Parathyroid hormone or Colip's hormone is the major regulator of the levels of calcium, magnesium and phosphate ions in the blood. It increases levels of calcium in the blood. Its secretion is regulated by the calcium level in the blood. Bone tissue acts as a storage reservoir for calcium, and parathyroid hormone stimulates the removal of calcium from the bone to increase levels in the blood. Therefore, it stimulates osteoclast activity. It increases the reabsorption of calcium by the renal tubules of kidney so that less is lost in urine, but at the same time it stimulates the loss of phosphates in the urine. It also stimulates kidneys to secrete calcitriol, which in turn increases calcium absorption from the digested food in the gut. Parathyroid hormone is thus a hypercalcemic hormone, that is, it increases the blood calcium levels. Now, moving on to the functions. Parathyroid hormone is the most important regulator of blood calcium levels. The action of parathyroid hormone on calcium regulation are shown in figure. We will now describe the effects of parathyroid hormones on different organs. Firstly, on the kidneys. Parathyroid hormone has 3 major effects. It increases calcium ion reabsorption by stimulating active uptake in the distal convoluted tubule and thick ascending limb. It also increases phosphate ion excretion by inhibiting its uptake in the proximal and distal convoluted tubules. This causes more ionized calcium to be free in the circulation. It also stimulates an enzyme 1-alpha hydroxylase that activates vitamin D. Now, its effects on the bones. Parathyroid hormone also causes the release of calcium and phosphate from the bone. It stimulates osteoblast proliferation and differentiation, and therefore it increases bone production. Parathyroid hormone receptors are not found on osteoclasts, but these cells are stimulated indirectly by factors released by the activated osteoblasts. Upregulation of osteoclastic activity causes increased bone breakdown. The resultant increase in bone turnover can have different effects on net bone mass, but always results in increased serum calcium. The actions attributed to this are direct inhibition of osteoblast collagen, synthesis, indirect stimulation of osteoclast bone erosion, increased collagenase synthesis to erode the bone, increased hydrogen ion release to create an acidic environment to enhance bone erosion. Now let's discuss the effects of parathyroid hormone on the intestines. Parathyroid hormone may have a direct action on calcium absorption in the upper small intestine, but this is unproven. The major effects are indirect by stimulating 1-alpha hydroxylase. This causes the production of calcitriol, which promotes calcium and phosphate reabsorption in the intestine. Although parathyroid causes increased mobilization of phosphate due to the parathyroid hormone mediated excretion of phosphate in the kidney, the overall effect is to reduce serum phosphate levels. Now, coming to the control of release, that is regulation of parathyroid hormone. Unlike other endocrine hormones, parathyroid secretion is not controlled by the anterior pituitary gland. Rather, its secretion from the parathyroid chief cells is determined by the circulating blood level of ionized calcium. A low plasma calcium concentration directly stimulates parathyroid hormone release by the parathyroid glands, and a high level suppresses it by negative feedback effect. The latter effect is opposite to the more general effect of intracellular calcium ions in promoting cellular hormone release, and is believed to involve a G-protein coupled cell surface receptor for calcium ion. Plasma magnesium has a similar though weaker effect than calcium ion on parathyroid secretion. The physiological relevance of this, however, is uncertain. The plasma phosphate levels have no direct effect on parathyroid secretion. The active vitamin D metabolite 1,2,5-OH-2D3 can, however, reduce parathyroid hormone production by the parathyroid glands. Now, we will discuss the clinical disorders of parathyroid hormone. Since parathyroid hormone is the most important hormone in the calcium homeostasis, disorders of this system are grouped according to their effect on the parathyroid hormone release. The two groups are hyperparathyroidism caused by excess of parathyroid hormone, hypoparathyroidism caused by the deficiency of parathyroid hormone. Now, let us discuss about hyperparathyroidism. It can be grouped into primary hyperparathyroidism and secondary hyperparathyroidism. Now, we will discuss the primary hyperparathyroidism. It is caused by the excessive release of parathyroid hormone. All the actions of parathyroid hormone raise calcium levels, due to which hypercalcemia, that is, excess blood calcium, results. Hypercalcemia and excess parathyroid hormone cause the symptoms as shown in the figure. Prolonged hyperparathyroidism causes bone demineralization and softening, called osteomalacia in adults and rickets in children. The symptoms and signs of this disease are depicted in the figure. Primary hyperparathyroidism is a relatively common endocrine disorder affecting about 1 in 1,000 people, and it's especially common in postmenopausal women. Its main causes are parathyroid gland adenoma, diffuse parathyroid gland hyperplasia. Now, neoplastic chief cells are not inhibited by high calcium, and consequently, parathyroid hormone secretion is unregulated. Malignant tumors of the parathyroid gland are very rare, but they can be associated with other endocrine tumors in multiple endocrine neoplasia syndromes. Now, we will discuss the main symptoms of hyperparathyroidism. It's investigated by blood tests measuring fasting serum calcium and phosphate. This will show raised serum calcium and reduced serum phosphate. Measuring blood parathyroid hormone if increased. Measuring renal function. This is often normal but should be measured as a baseline. Radiography may show subperiosteal bone resorption of the phalanges. Now, radioisotope scanning or ultrasound of the parathyroid glands to detect adenomas. Elevated serum alkaline phosphatase may be seen in parathyroid bone disease. 24-hour urinary calcium should be measured in young patients who present with a moderate increase in serum calcium and parathyroid hormone to exclude familial hypocalciuric hypercalcemia. Additionally, an abdominal X-ray could be performed to detect nephrocalcinosis or renal calculi due to hypocalcemia. Medications should be reviewed. Common medications, for example, lithium and thiazide diuretics, can cause hypercalcemia. There are three treatment options. 1. Restrict dietary calcium and vitamin D and encourage adequate hydration drug treatment. For example, calcitonin, bisphosphonates, cinacalcet in certain patients. This is reserved for patients who do not fulfill the criteria for surgery. Also, surgical removal of the parathyroid gland. Some indications for surgery include patients under 50 and patients with a serum calcium greater than 3 millimolar per liter. Now we will discuss about the secondary hyperparathyroidism. Many diseases can cause hypocalcemia, for example, chronic renal failure, which stimulates parathyroid hormone as a compensatory response. If hypocalcemia is prolonged, the glands enlarge by hyperplasia to secrete excess parathyroid hormone. This is called secondary hyperparathyroidism. It is characterized by raised parathyroid hormone with normal or low serum calcium. Now the causes of secondary hyperparathyroidism. Hypocalcemia can be caused by chronic renal failure, vitamin D deficiency or malabsorption. In chronic renal failure, the kidneys fail to reabsorb calcium. Renal osteodystrophy is a complication of chronic kidney disease characterized by secondary hyperparathyroidism, osteomalacia, vitamin D deficiency. It's caused either by impaired 1-alpha hydroxylase activity in the kidney. This leads to reduced vitamin D activation and less calcium reabsorption. This increases parathyroid hormone production or impaired phosphate clearance by the kidney. Hyperphosphatemia reduces the amount of ionized calcium, leading to increased parathyroid hormone production and also parathyroid hormone induced reabsorption of calcium from the bone, leading to bone marrow fibrosis and cyst formation. This can be identified radiologically and is called osteitis fibrosa cystica. Now, vitamin D deficiency. Vitamin D deficiency can occur if the diet is deficient in vitamin D or the skin does not receive adequate sunlight. For example, people who spend excessive amounts of time indoors or extensive skin covering of the right wavelength to produce vitamin D. Deficiency of activated vitamin D causes hypocalcemia as a result of impaired calcium absorption in the intestines. Reduced intestinal absorption and reduced mobility can occur in the elderly as a normal process, so they are at a higher risk of developing vitamin D deficiency. Clinically, there is a normal amount of bone, but it does not mineralize fully. Osteomalacia in adults, rickets in children. Treatment aims to correct the cause. This may include dietary modification or phosphate binders, vitamin D analogues, modification of dialysis, cinacalcet. This is not recommended for patients with end-stage renal disease on dialysis. Coming to the tertiary hyperparathyroidism. Tertiary hyperparathyroidism is a complication of secondary hyperparathyroidism and is seen in patients with renal failure. If secondary hyperparathyroidism persists, the level of calcium required to inhibit parathyroid hormone production by the parathyroid gland is reset to a higher level. This causes autonomous parathyroid gland activity and also hypercalcemia. Parathyroidectomy is often indicated at this stage. Now, familial hypocalciuric hypercalcemia. This is a rare genetic condition which is characterized by raised renal reabsorption of calcium in the presence of hypercalcemia. It is caused by a mutation of the calcium sensing receptor in the parathyroid glands, resulting in deficient binding, and this raises the set point for calcium homeostasis. Diagnosis depends on family history and a reduced calcium or creatinine clearance ratio in blood and urine samples. No treatment is indicated and parathyroid surgery does not solve the problem. Now, moving to the hypoparathyroidism. Hypoparathyroidism is the deficiency of parathyroid hormone, resulting in hypocalcemia. It causes the usual symptoms of hypocalcemia as shown in figure, but without osteomalacia. The main causes are complications of thyroid or parathyroid surgery. Second, congenital deficiency or Di-George syndrome. Idiopathic hypoparathyroidism, an autoimmune disorder. Pseudohypoparathyroidism, congenital parathyroid resistance. Investigations reveal reduced serum calcium and increased serum phosphate. Pseudohypoparathyroidism is the result of resistance to parathyroid hormone. Patients have raised parathyroid hormone with symptoms of hypoparathyroidism. A persistent low plasma calcium level can induce hyperexcitability of nerve and neuromuscular tissue, characterized by a tingling sensation in the face or fingers, muscle cramps and spasms. Second one, Chvostek's sign, a twitching of the facial muscles following light tapping over the facial nerve, and also Trousseau's sign, a characteristic tetanic spasm of the wrist and fingers following over inflation of a sphygmomanometer cuff placed over the upper arm for more than 3 minutes. Now, dental abnormalities, dry scaly skin and hair, brittle nails and cataracts may also be present in more chronic persistent cases. If hypocalcemia is suspected on clinical examination, the common causes can be recalled using the mnemonic Harvard, that is hypoparathyroidism, also hyperphosphatemia and hypomagnesemia, acute pancreatitis, renal failure, vitamin D3 deficiency, alkalosis, rhabdomyolysis, drugs for example bisphosphonates. Now we will discuss the treatment for hypoparathyroidism. Depending on the severity of the hypocalcemia, this requires administration of vitamin D supplements in the form of calciferol tablets or an oral solution of the vitamin D derivative dihydrotaxisterol to enhance calcium absorption and utilization. This must be coupled with frequent serum and urinary calcium measurements to ensure that overtreatment and consequent hypercalcemia does not occur. Careful dose adjustments should then be made in order to maintain a normal blood calcium level. In acute cases of hypocalcemic tetany, a more rapid elevation in blood calcium may be achieved by means of an intravenous infusion of 10% calcium gluconate solution given over 10 minutes or longer as needed to counteract symptoms. Parathyroid hormone itself is not available for replacement therapy. Now, osteoporosis. Osteoporosis is a disease characterized by low bone mass and deterioration of bone sufficient to cause bone fragility and an increased risk of fracture. It's defined as a bone mineral density 2.5 standard deviation below the mean bone mineral density for young, healthy adults at peak bone mass. Osteopenia is defined as a standard deviation below normal bone mineral density. It's caused by increased osteoclast activity and breakdown of bone and decreased bone formation by osteoblasts. This causes loss of bone mass. However, adequate mineralization still occurs. Since new bone is poorly formed, microfractures cannot be repaired, so the bones become thin and brittle. Loss of bone is a normal part of the aging process. However, women are at a great risk due to the loss of estrogen production after menopause. There are a number of other risk factors for osteoporosis, including family history of osteoporotic fractures, rheumatoid arthritis. Also, long-term corticosteroid use, alcohol intake of greater than 4 units per day and smoking, vitamin D deficiency and hyperparathyroidism in the elderly. Osteoporosis is responsible for approximately 180,000 fractures in England and Wales every year. Management comprises prevention and pharmacological treatment. Strategies include calcium and vitamin D supplements, exercise, physiotherapy assessment for risk of falls, also smoking cessation and avoiding excessive alcohol. Dear students, it was all about today's lecture. Hope you have understood it well. Thank you and goodbye.